Welcome. Today we get to learn about thoracic spine objective assessment. First off, you do want to check your posture on your patients. The posture will, of course, show you what things might be wrong at the thoracic spine. Tying in with yawn and upper cross syndrome, it'll tell you then what muscles you specifically need to palpate, as well as possible stiffness of the thoracic spine segments. It also will help cue you in on areas of the cervical and thoracic spine that you need to screen out, because as always we should screen out the joints above and below, in this case the region, the cervical and the thoracic region, or I'm sorry, the cervical and the lumbar region that is above and below the segments. Then we move into our active range of motion, and I have Luke to help me out with that. All right, everyone, this is Luke. He's going to help us out today as our patient. You going to wave at the camera? All right, so the first thing we're going to look at here is our active movement assessment for the thoracic spine. We talked about needing to do the cervical and the lumbar screen, so now we're moving into trying to focus our range of motion at the thoracic spine. So if you notice there in the picture, let me have you try this. Put your hands behind your neck. That's going to help block out the cervical spine. So now as he moves forward into flexion or extension, that's going to be blocked out for us. The next thing that we're going to have him do is he's sitting on the table. That helps lock out the pelvis, the hips, and a little bit of the lumbar spine. So in this case, it's actually not as good as if, let me have you face this direction. We'll pretend like his legs are hanging off the table. I'm just going to have you curl forward as far as you can there. So now I can watch through his thoracic spine here and seeing where that bend is. So in this case, I see the apex happening about here, which makes sense. That's pretty normal. It's hard to do an objective measurement. There are some possible ways of doing that, but nothing much for this course. I mean, you can get a tape measure and you could do C7 down to the PSIS, and then as long as you're consistent from one day to the next, you can set some goals with that. What we're really trying to look for with this is if it causes any of the symptoms. So let me have you do that one more time. Reach behind your neck, and it's tucked forward. So now, does this bother you? Do you have any pain with this? Do you feel anything, or just stretching? Just stretching. It's harder with younger kids, right? So then I can come in here and add some overpressure. So he's just being a little bit silly with me, but see, I can add some overpressure through his upper thoracic spine to go further. Did that bother you at all? He would probably say no. So then he's cleared with flexion. Go ahead and relax a minute. You can sit off the edge again. Okay, so the next one we're going to look at is our extension. So same sort of thing, you're reaching behind the neck, tuck those elbows in front of you, and I'm going to have you look as far back as you can. So there he goes. So now he's getting, again, that extension through there. In his case, he's not getting very much extension. I see a lot happening with his neck, so let me, hold on, relax, Luke. You just sit here normal. Let me have you lock your fingers together. And now reach behind your neck. So that should help lock your neck. So now I want you to arch from your back. So see, just by doing the technique properly, now we're seeing a little bit more. But probably he's hunching forward with screens or just, kids are naturally more in that fetal position. He's actually lacking some extension, and you'll see that with many of your clients. But as with the picture, that's more what we expect. The same sort of thing, you look where they have that apex point, and if they truly are getting some. All right, so now we're going to try the side bending. Let me have you reach behind your neck. And now you're going to try the side bend. You're going to try to tilt to one side, just like you see in that picture. So keep your head straight forward, and then you just come down to the side. He's a little bit of what we call a motor, more on. Okay, come on back up. Let's go the other way, like you're trying to tuck to your side. So in this case, I'm more feeling. Again, with both of these, I didn't show you with extension, but you can always add that overpressure, and you're asking the patient symptoms with this. It's pretty straightforward if you just look at that picture. The last one for us to add is the rotation. Let me have you give yourself a hug. Okay, now we're going to have you look over your shoulder as far as you can. The same thing, you can always add in some overpressure through here, asking symptoms. Does this bother you at all? Nope. Your familiar symptoms at all? Nope. Okay, let me add in a little bit of overpressure here. Did that change your symptoms any? No, it's still the same. Well, then we're cleared out. So then we try the other direction. Okay, so try the other direction. And then I can add a little bit more. So that's very similar to that lumbar spine. The last one we can do is kind of part of range of motion testing, especially with screening out his lumbar spine, neck, and then we just did thoracic, is now the shoulder. So what we're going to do with this is I'm just going to have you raise your arm up.
I did.
Yeah, as far back as you can. Good. Okay, go ahead and relax, bring it down. Just bring it down like normal. Okay, so let's just watch him here and see what his thoracic spine does if it shifts at all. Let me have you raise up your arm again. So I think he's reaching really tall, as high as he can. Maybe the cue you would use is just kind of reach up and back as far as you can, because it's very normal. What we're looking for on this one is for them to be lacking shoulder flexion. Go ahead and relax now. You're going to be lacking shoulder flexion, and then as they're lacking that shoulder flexion, they compensate by then side bending to get that last little the last couple of inches that they're trying to get there. If they're doing like Luke, where he has full shoulder flexion, and then to reach even higher, he then side bends to get those couple inches, that would be a normal response. So you can just maybe use the cue of, let me have you raise your arm up. As always, please practice all of these techniques. Feel free to stop or pause this video and go over any of the techniques that I've gone over with you. If you have any questions, maybe note in the notes in your PowerPoint, so that way when we meet together on Friday, we can address any of those. It could be something to do with hand position, something you can't see well on the video. Please note these things ahead of time so we can roll forward. But again, back with posture, we do want to remember those things. You can look at some photos of people, or somebody at home, go ahead and assess their posture and see how that might tie in with the thoracic spine. Moving on, after range of motion, we have the vertebral compression fractures. I'm going to show you a few techniques to deal with that. We do have the slides to read, but different ways to screen that out, and I assume you'll have other times in the program. But in this case, we're doing the vertebral compression fracture. We want to load the spine with them standing, and then we're just applying a little bit of a percussion to it. Okay? With that, we're seeing if we can reproduce their symptoms, having that sharp sudden pain. From there, the other test we have, let me have you lie down on your back, please, Luke. And hopefully this camera's pointing at it just right, is the supine test. They're going to lay down on their back. They get one pillow. Sorry, I don't have it here. You can use your hands for a pillow. So he has this one pillow there, and then we're just asking him if he has severe pain with that. And again, this is going to be someone that you're expecting a compression fracture. Of course, lots of people have pain lying supine, but this more ties in with a specific population. Now with the passive accessory tests, we're going to go over those with Luke right now, so I will show you how to do each one of those on a person. Again, please practice these things. If you have any questions, note them. If you run into any problems, whatever, I'm happy to go over those with you. In terms of palpation, other than knowing the segments and where things are located, the actual soft tissue and the muscles, we will go over that with our treatment for next Wednesday. All right, now we're going to move into some of the palpation. First thing we want to do is palpate C6. If you just have them tuck their chin down a little bit, that first bump you come to would be C6. The next one you come to, you'll notice, is a little bit larger, just like we see in the picture, and that's going to be more like C7. They don't have C6 circled. Then from there you go down even further. T1 tends to feel, to me, a little bit sharper. It's not like C7 is more like a medial malleolus, it's larger. where T1 might be more prominent, but it's more like a point, like a mountain peak. Then from there, you can try to count down. Him, it's very obvious. It gets a little bit mushy here, and then it gets obvious again through there. The other thing we do is we come down to the bottom ribs here, and then you just kind of follow them up, and you would assume that's T12. So you kind of do your numbers that way. Of course, when a patient is prone on the table, then the same thing can be done. We're very good with the lumbar spine and where we're palpating there. So same sort of thing. As long as you know where L1 is and you kind of have an idea, and you know where C7 is, then you'll be able to get within 1 or 2 levels of the T-spine. It's very normal for me as I'm counting down the T-spine to only come up with 10 or 11 segments on certain individuals. On Luke, I would assume I'd get all 11 or 12. Some of the major things that we need to palpate, I mean, most of these are going to be straight off of your anatomy, so we don't need to go over those now, but just see if you can be familiar with palpating those. Specifically with the muscles, we will get into that. I mean, definitely want to know spine to the scapula, definitely want to know like your inferior angle and all of these other areas of the scapula, and then like we said, the spinous processes. Other than that, we'll talk in a minute about palpating the transverse joints, the costotransverse. With soft tissue, specifically the muscles, we'll get into that with treatment, doing the soft tissue mobilization. So, first thing we're going to get to, let me have you lay down on your stomach. Sorry, it's a little cold, bud. So, on your stomach, on the table. There we go. All right. So, for Luke here, can you get your arms by your side? I'm going to tilt down the screen just a tiny bit. We have our normal PAs. That's very much the same as what we've done in the lumbar spine. We're simply starting here and moving our way up, just like we're used to. Maybe a light one at first. Do you feel that? Is that okay? Probably not. Doesn't like me squishing his guts out. Your adult patient probably will be okay with this. So then I might go into some deep ones. How about that? Or maybe you start at the beginning. Let me know if any of this really bothers you, okay? So I'll go light. If that was really bothering him, he would jump and yell at me. If not, then I can do a little bit deeper, and then finally bottom out. Hit that full, like R2. That's fine. I'm going to move up a level. 1, 2, 3. That's fine. I'm moving up a level. And you just try to get, like I say, 10, 11, if you're lucky, all 12 levels there for the central PAs. For the unilateral PAs, that's where we're trying to find those transverse pillars, the transverse processes, I should say. So with that one, you're going to go about 2 thumb widths off of the spinous process. Go ahead and come on down. And it's very much the same way like we're used to. So I go 2 thumb widths, or about 1.5 inches. And then usually we'll kind of do those thumbs so you know you're right on those rib heads, right on the actually the costotransverse, where the rib and the transverse process comes together. Keep your arms out. You can turn the other one side. In his case, thumbs would be best because it is a smaller frame and it's very hyperlocal, so I'm just assessing it. And I can very well feel those articular pillars. His paraspinal muscles are staying medial to that. Generally on patients, when it's in my clinic, I may do much more of that general hold. So then I'll just kind of go along those rib heads and just see if I can reproduce some of that familiar pain. Lots of times when somebody has rib pain, for example, I'm trying to assess, is this more of a lumbar spine, a thoracic, like a spine issue, or is this more of a rib that's stuck or displaced or whatever has to do with that. You go back on your stomach just a little more. So with that then, if it's a spine thing, the central PA would bother them. If it's where that rib attaches, you might go on that level, and they might describe the rib pain that they're having across their anterior thorax, and that's from you pushing on that head, because it's almost like, imagine that rib like a C shape. That C shape is being thrust forward as you're pressing on that rib head. Otherwise, if they're just describing local low back pain, and it's not radiating around the side or anything, then just pushing on that spot, you're just trying to reproduce their symptoms. And then we'll get into more rib stuff later. A question many of us have with the unilateral PAs is the location of the transverse processes, or this costotransverse joint. If you'll look carefully on the slides, they do show some of these segments and kind of give you some rules to look at. We call them the rules of three to find those transverse processes. So in this case, you're going to start at the transverse process and then follow the rule. I personally think this is a lot of verbiage. It's hard to understand. So I prefer following this diagram using this picture. I've added a few notes on the sides here that show examples. I tend to be an example person, as you know, so it helps me to understand it better. So first up, we have the T1 through 4. That's the first rule of the rules of three. With that one, you are going to look for the transverse process 1 interspinous space above. So quite just straightforward with that. If you're looking, let's say T3, if you'll go 1 interspinous space above, then that would be T3, and then that interspinous space would be between 2 and 3. So spinous process T3, you come up halfway to T2, you would go over the 2 kind of thumb widths, about 1 inch and a quarter or so, and then you're gonna, the bump you feel there would be the transverse process of T3. Again, in between the spinous processes of T2 and T3. Most people, you're going to be able to feel the actual bump there and know you're there. We call them the rib humps and some of that sometimes. If not, just be confident in your anatomy and where you are, and then you can apply your pressure at that point. As you move down, the next set of rules is T5 through T8. And with that one, you're going to actually go up 2 interspinous spaces. So very straightforward. If T7 spinous process is here, you'll move up 1 space, 2 space. So that's now between 6 and 5. Then you'll come out again, those 2 finger widths, and then you'll be confident the bump that you're on there would be the transverse process of T7. Again, if you can't feel a bump, you at least know the general region for it. You apply a posterior to anterior pressure or thrust. I mean, not an actual thrust for cavitation, but like a grade 3 thrust, and gather the subjective response for that. Finally, the most confusing, but again, it's very actually straightforward. Don't get lost in the minutia and the specific details with this. The last one, it describes it as being at the base of the spinous process. If you look at where the base of the spinous process is, it's essentially 2/3 or 3/4 of the way through that interspinous space. In reality, that space is so small, you can almost just consider it to be like the first rule, where it's just in between that area. But for more specifics, if we call this T11, T10, and T9, if you're looking for T11's transverse process, you start at the spinous process, you come almost all the way to T10, you go over those 2 widths, and again, that's where you're expecting it to be. And again, if you're using more PC form general contact, you're really just going to be moving up that lateral spine anyways. And then if you find something that seems to incriminate the level that you need to target with your future treatments, then you might just come over to the spine, say, hey, I found it here on this transverse process, whatever that is, let me come over, let me now count down or count up and see where I am. And if you were to end up, say, at between T5 and 6, then you would know it's the T7 transverse process, and now you can note that. So hopefully this all makes sense. Otherwise, read through this. You can research some things on Google, but in terms of test, it'll be right off this slide. All right, now that we've done the posterior to anterior pressure, now we're going to look at the transverse glides. This is very much in the same category as the unilateral PA glides, but now we'll be pushing through the spinous process. If you can imagine, you have your spinous process with your transverse processes on each side. We started with the central PAs, trying to elicit familiar symptoms and assess the mobility. Is it normal? Is it hypo or is it hyper? Now we did the same things with the unilaterals. As you do that to the one side, you're actually testing that rotation. So in this case, let's call this the left side. If I'm pushing here, I'm seeing how that then rotates. And then the same thing on the other side. Well, let's say there's some extra tenderness, and for whatever reason, you can't push through that segment, or it's giving you false information. Because the the spinous processes stick up so high in the thoracic spine, you can also push on the spinous process to elicit that rotation. And that'll help you assess the overall mobility and tenderness of the rotation of the thoracic segment. So what that looks like is I come in here to where the spinous processes are, and just like you see in the picture, it's like he's looking down because he's looking in the line of force where he's pressing. So again, I am pushing in this direction from Luke's left side to his right side. So coming down here, if that's T1, 2, 3, let's start from T3 here. I'm getting nice rounded thumbs there, and I'm pushing laterally. Again, or I guess in this case it would be medially, but I'm pushing from the left to the right side. That's in that frontal plane, where the other things we were doing was in the sagittal plane. And same thing, what does that feel like? Do I feel like there's a little bit of give in this young, healthy spine? Absolutely, there's tons of give. I'm feeling that thing rotate. So now I'm just moving down each of these levels. In the picture, you'll see him, he's using those extended thumbs. I don't see any reason why you can't get nice flex thumbs, use your fingers, and save the joints. So I'm just, again, moving down the levels there and looking. Does that bother you at all? I got to a level that was just a little bit stiffer there. It wasn't giving like the other ones, but normally I would ask, does this bother you? Okay, how about here? Is this your familiar pain? Whatever expression you want to use. Okay, for the next one, we're going to now go into some of the ribs and see how the ribs attach, in this case, to the sternum, and we're checking for that hypomobility and tenderness. So just as we see there in the picture, we're able to do that. So I'm going to come here on Luke. Is it okay if you put your arms by your side? So I'm going to come in here. Again, with females, we want to be careful that we aren't touching areas that they're not comfortable with. As we mentioned before in class, you can have them reach up, essentially, hey, anything I shouldn't be touching, why don't you hold on to that there, and that'll keep me from doing that. I'm going to start up, there I'm feeling his clavicles. I'm going to come inward, and then I'm essentially assessing each side of the sternum. You'll feel little bumps here. So then I can just press down. My middle finger is a little longer, so I just like to kind of almost bridge my other fingers together and let that middle finger then press down. And again, keep me from touching extra tissue here, but I can just kind of apply that anterior to posterior force as I run down the inside of the sternum. Does that bother you? No, you're fine? So then I can just run down and follow that attachment. As the whole xiphoid process, be careful, you press through that and you could actually cause a little subluxation or even a little fracture there. But just to the sides, again, checking those kind of top 3 to 5 ribs. During our examination of ribs, one thing that we are looking for is the relationship between one rib and another. And as we see in this slide, basically, if a rib is fixed to the other rib, in this case above it, cranially, then you'll imagine that rib right below it, it's still going to be in its normal location in relation to the other inferior ribs. So if this one is now being pulled up, imagine spasm of the intercostal muscles, then that gap is going to be larger. So that is what we're trying to palpate, be it statically while a patient's just laying down or seated, or as we start distracting the shoulder, you might feel either lack of movement or increased movement at certain levels. All right, ready? So now we're going to move into rib palpation. We have a funny picture. This is compliments of Dr. Jenna, meaning she provided the picture. That is not a picture of her. But in this, you can essentially get in front of the patient. Go and relax with your arms by your side there. Sit up a little bit straighter. Okay, so now from here, I can come in and just feel the ribs. And what I'm looking for is to just look for any asymmetries. You may notice that you have normal spaces that are about the width of my finger in between each of his ribs, but then I get to a certain level and that space is smaller. Or maybe the space is larger with the level above that. We're assuming at that point then that maybe a rib is stuck to another one and it creates that gap. So that's kind of what you can do. That's a position you can test from. From there, let me have you going back again. The same thing can be done while they're laying down. Again, assessing both sides. Again, with females, you could very comfortably lift the shirts up to here, or I'm imagining a sports bra or something, just have even the shirt off. But that can be done in that position. Let me have you go on your stomach real fast.
Okay.
We can also assess the posterior rib, same thing, just looking for gaps in between those segments. We are going to get into some spring testing and different things, but I just wanted to make one more note about the ribs. I have many patients who come in and they'll talk about a rib pain, say through here. Once I've screened out the gallbladder and other non-musculoskeletal complaints, then I want to know, is it a fractured rib? Is it a stuck rib? Or is it just the intercostal muscles, the muscles in between the rib that are spasming, and that's causing them the pain with coughing or deep breaths or even just rotating their torso. So when it comes to this palpation piece, I'll lightly press on that local rib and I'll make sure I'm just on the rib itself. And they say, it's a little tender. And then I'll get into the space right next to the rib and I'll either press down or just move my finger back and forth like we've done with some of our soft tissue work, think like friction there. And oh yeah, that's sharp pain. And then I'll go to the next rib, I'll press that rib, maybe it's a little tender, I'll come back to that groove, oh yeah, that's a lot of pain. Well then I know it's just that those muscles are spasming. It's a trigger point or it's a knot. It's some sort of dysfunction of the muscle. But if on the other hand, it's like, yeah, it's a little tender in there, but then I press on the actual rib and oh yeah, that's my pain. Well, I'm going to keep chasing down the rib with other rib assessment. So that's kind of how you differentiate out rib muscle versus rib bone pain that a patient might have. So from there, we move into some of our other testing, and that is the spring testing, as we call it. So as you see here, with the position in this picture, you're going to cross your hands, and you're going to be thrusting through the ribs on the one side, but in doing so, the patient essentially can kind of wobble on the table. You're not pinning down that rib. So while this one hand, I'm checking his right side, so my right hand is now thrusting, not a grade 5, but like a grade 3, I'm now applying pressure through what we call that rib hump, just on the other side of the transverse process. Well, we want to make sure the transverse process is not just flexing with it, because then we can't really assess the ribs. So we can lock down the transverse process, mind blown, from the other side. So in this case, the spinous process, I'm now going to be on his left side. I'm going to get right in the groove just next to his spinous process, so that way I know I'm on the vertebrae and not on the ribs. That's now pinning down in this case on him, it would be like T3 through T5. Well, then I can come over here. Again, I'm making sure I'm now lateral, so I'm not on his spine. So now I can press posterior to anterior on his rib surface. So it's posterior to anterior with my right, blocking the spine with my left. So now I'm moving down. Again, I'm just lateral to the left of the spinous process, which means I'm now pinning down and not allowing the vertebrae to rotate from anterior to posterior on his right side. I'm now coming very far lateral, well beyond those 2 finger widths. And now again, I'm pressing through. And I'm assessing, just like we did with our PAs, how springy is it? How far does it go? Does it cause any of his symptoms or any of his pain? So essentially I can move until my mechanics won't allow me to go any further. He's close to the camera here. Normally I'd have him much closer, so it'd be very comfortable for me. Oh, excuse me, bud. Guess it's that coronavirus. You just had to cough real fast. Come on forward here. So now, at a certain point, it doesn't make sense for you to reach any further. Also, you get some of the mechanics going on with the transverse processes. That's more of a spinal thing, but it still may, or I should say the facets and the spinous processes, but mostly for mechanics reason, but also mostly for therapist mechanics reasons, but also possibly the mechanics of the thoracic spine. It makes sense to check the lower ribs from this more caudal position or view. Same exact thing though. In this case, I want to thrust through, kind of again at this diagonal, this angle here. I'm thrusting through, in this case, his left ribs, and actually I'll get out of the picture and I'll keep going with the right. So now I'm imagining 2 fingers widths out, maybe his, and follow the ribs up, so T12 starts here. So maybe his transverse processes are out here. So I'm going to go just further, and now I know I'm on the ribs. So I'm going to use my right hand to block the transverse processes on this side. Now I am within that 2 finger width. I'm only 1 finger width away, locking out just next to T12, while I now push over here. And we just always want to be careful with those floating ribs anyways. Mostly we want to check the higher ones where they're complaining of their pain. So I'll now move up a little bit, getting closer to the truer ribs there, and doing the same thing, blocking out the spine while I now push on those lateral ribs. Block out the spine where I push on those ribs. And again, I'm aiming in that direction, just like with the dead man, that kind of down and away forming an X. And at some point, you're going to have some crossover, checking more like T, like the rib that goes in a T5, that 5th rib. And maybe I checked it from the top and the bottom. But those bottom kind of T10 through T5, I'll check those ribs from this inferior position. Okay, so after we've done the spring test and things, now we do want to just more monitor how the ribs are moving. You might call this the PIBMs of the rib assessment, except it's not really physiological, but it's just that still idea where you're going to be passively moving the patient, and while doing so, in this case it will be using distraction of the shoulder, it will create a gapping of the ribs. Well, you'll try to monitor those ribs, because it'll feel like right now your finger is resting on those ribs. So it actually looked like this. Well, as you gap and distract that shoulder, it'll create space in between the ribs. The same thing happens if they take a deep breath. That excursion of the ribs is going to happen. Well, if you have your finger in between all those ribs, you'll feel if a certain segment isn't moving, because you'll feel a gap and you'll be able to press further down in the ones that are moving. But the one that's not moving, it'll just stay hugging your finger in the same way. So hopefully that makes sense if I move here. So in this case, if he has good shoulder mobility and no major pathology, I can raise his shoulder all the way up, and you can even just see his ribs being exposed there as I tug on this. So again, I'm not going to tug. It's like I'm playing the piano here. I'm in the rib space. I'm right on those intercostal muscles. And he's actually grabbing on my elbow a little bit, which is just fine. That helps just lock it so I don't have to do as much. But be careful of skin burns here. You almost want to push a little bit of skin down, then have a nice pinch, because then as you pull up, there's some room for the skin to stretch with you. So again, I'm going to start nice and low here, and I'm going to pull, and I feel that gapping there. I might come up one level, so I'm just feeling with different fingers, and then one level, and I just keep coming up as far as I can. And I'm just, again, monitoring, seeing if one level is not moving right. If you need to only do one at a time, or maybe 2 fingers, because you can't pay attention to all those proprioceptors of all your fingers, or the mechanoreceptors, that's totally fine. But again, there should be some natural separation that's happening there. The last one we are going to get to is the upper ribs. With this one, your patient needs to be more supine. Like on your back here. And now you're kind of coming into the ribs through the armpit here. Again, being careful and conscious for breast tissue. From here, I can very comfortably, I hope I don't lose the screen or the laptop on the stand, but if I turn just a little bit more, I think we'll be able to see a little bit better. So from here, again, if I can give a little more skin to him and then lock down, that gives me the freedom to pull. So maybe make sure that's working first before you start monitoring. I definitely can still feel and see what's happening with the actual ribs. Thanks for helping. But in this case, this is the one chance I have to monitor the upper ribs. So I can come all the way underneath the pec here. And I'm getting really close to maybe that 3rd rib. And then I can, sorry, I'll try not to tickle you. And then I can place my fingers all the way down, good piano fingers there. And now I'm just pulling on it and monitoring. I'm feeling a lot of movement with those first two. So maybe I'll now move down, check the next one. Move down. And move down. And again, very subtle, but you'll just feel some slight gapping. You want to know if it's normal or not, you then check the other side. Or you check under ribs and you check multiple people. Of course, we'd love time to check multiple people in the real lab, because then you would start to feel those subtle differences of what's very mobile and what's not. But again, if it feels the same across the entire chest wall, then you assume it's relatively normal. But if you get to one segment or two where it doesn't seem to be moving right, or while you were palpating earlier and you noticed there was a big gap and it was close together on the other one, then you start to get an idea that there's some dysfunction. So that was the one thing that really confused me when I was a student. It would be almost impossible for somebody to say, I have rib pain, and then you zip their mouth, and now you have to feel every single spot of all their rib to try to find it. Most of the time, they're going to point exactly where their rib pain is. So then you can just simply go to the joints above and below that part and really take your time feeling with pulling the arm, with doing spring testing, with doing PAs, if you can reproduce their symptoms. So again, it's kind of hard to practice this on healthy population, but don't get too caught up or fed up if you can't feel the subtle movements with this. It makes much more sense when you have one really close hypomobile locked up segment, and then the one next to it's very open and very hypermobile. So hopefully that all makes sense for you. Thank you all for putting up with me and with Luke. We certainly had a lot of fun doing this. Luke actually made $5. His intro to the Hollywood fame, as his mom stated. But sorry for the rough circumstances we have here. I hope as you went along you were able to note things. Otherwise, if you haven't had a chance to practice on a patient, maybe it'll be tonight or early tomorrow morning that you can finally practice on someone. Please note on any of these slides if you run into any trouble. And then again, come Friday, 9 o'clock, we'll meet up and answer any questions you might have. So enjoy yourselves.